So I'm going to be presenting at Mid-Atlantic AUA meeting on alternative intravesical therapies for high-grade PT1 bladder cancer, which is considered high-risk bladder cancer as far as the ability to progress and recur and cause significant morbidity and mortality in patients. And the gist of my talk is that we are going to compare BCG, which is in shortage on and off for the past few years across the world, and seeing if there are any alternative therapies that can take place of it with the equivalent efficacy. Looking at the BCG numbers from the data from a lot of the meta-analyses, we know that the recurrence-free survival, progression-free survival is in the upwards of 90s when the BCG is given as an induction therapy and the recommended maintenance regimen. Unfortunately, with the BCG shortage, a lot of the places are deprived of the BCG, and the AUA recommendation has been to either give an induction course and skip the maintenance if there is no availability, or come up with some alternative drugs to use. When we look at the data comparing the lower BCG dosage versus kind of reduced frequency of BCG, we know that reduced frequency of BCG is gives substandard outcomes. It cuts about in half both the recurrence-free survival and a progression-free survival in the patients. So what we do is we look at other alternatives such as intravesical chemotherapy agents. The intravesical chemotherapy agents that have been used, sometimes on-label, sometimes off-label, are mitomycin, gemcitabine, epirubicin, adriamycin, docetaxel, and valrubicin. When we look at the comparison of these single agents to BCG, unfortunately, these numbers are a little bit lower than BCG. So we do need to come up with even better strategies. One combination that has come up in the past few years is the combination of gemcitabine and docetaxel. We have some real-world evidence, and unfortunately from retrospective trials mostly, that shows a fairly good performance of this drug regimen. These numbers are in the upwards of 80s in the BCG-naive patients and about 50% in patients who have failed BCG in the past. There was a single-arm trial that has concluded, or that has run at the Hopkins, looking at the BCG-naive patients who received gemcitabine docetaxel combination, and that showed about a 12-month complete response of upward of 80. So this is a fairly promising regimen for us. We do have a randomized trial open and running for BCG versus gemcitabine docetaxel that will give us even more robust data, and this trial is open in multiple institutions. One good thing to look forward to, there are a myriad of trials that are open and running in the non-muscle invasive bladder cancer space, both in the intermediate risk, high risk, BCG naive and BCG unresponsive, with very creative kind of solutions, and some immunotherapy agents and some other agents that kind of enhance the response of the bladder lining to the therapy to eliminate the cancer. And we know this will generate some very interesting data. So hopefully in the next few years, we'll have even more alternatives to the BCG.